I don't think we got your question, so I'm just flagging that as well.
Okay.
So.
And we've got, Allison, until 11:15.
Okay. All right. So do we have our panel members back? I see Brett. Okay. I think we have enough to get rolling. So I'm going to get us started. The very first question from folks is, what are the actual differences between the two models? Someone be able to answer that.
There's a few differences. I think, in the initial establishment of CCBHCs, what you're looking to do is, again, as I kind of mentioned in the beginning, you're creating your prospective payment rate off of what you need to do in the future. Oftentimes when you're looking at prospective payment, you may look back to see, well, what did we do and can we rebase, right? Is that need continuing to grow, and can we then create a structure to look at that? So the CCBHC model looks forward in a forward way. The CCBHC also can include the costs for those services that are kind of outside the scope by and large. So if I'm a substance use clinician provider, and in order to hire me, it costs X amount, but a portion of my time in service is for Medicaid, but other portions are for uninsured or for private payer. That cost for my whole salary is part of that rate, and not a portion of what we see as the just for that Medicaid service or Medicaid population. So you're really looking at kind of that future need. What does that future need look to hire someone to be in that role? So there are some more behavioral health specific kind of developments within this that are to alleviate that workforce burden, but also to kind of match that need, right? So if I were a child specific provider, or if I had unique trainings for a population, there are some of those kind of differences in that structure. It's also, population base is different, right? So the primary focus for the CCBHC is to treat people with mental health and substance use needs, right? So I'll quote Dr. Anita Everett, who leads the work at SAMHSA on mental health and substance use. So she defines the model as, if you have a person with a substance use or mental health condition that you care about, the CCBHC is where you want to take them. And oftentimes when you see if somebody were raising their hand or saying that they needed care, they may look to a clinic that may specifically provide that. Whereas the primary focus for FQHCs is that still person-centered focus, but a much broader diversity of conditions when you're looking there. So a bit of a balance there. I hope that gives a bit of focus, because as I said earlier, an FQHC can be a CCBHC. You can add that certification to it as well, if that makes the most sense for that particular community and population. So it's kind of like how a rectangle isn't a square, but a square could be a rectangle. And so when you're thinking about it, there are a lot of overlaps, but those overlaps are synergies. And I think that's just important to note.
Thanks, Brett. One quick follow-up, because you've mentioned the prospective payment being such a big part of the difference. When you're paying for things that are projected, most of the prospective payment models I'm aware of have a reconciliation process. Does the CCBHC budgeting account for, at the end, did you actually do what you projected, and is there a reconciliation?
So there's two different points there. One is, so yes, you can kind of reconcile and rebase, if you look at your data and say, okay, we either undershot or overshot, right? So there's kind of there's risks on both sides, right, with the state and with the clinics. But another component of the CCBHC is the quality bonus payment. So you can say, well, in order to be certified and receive the PPS rate, you have to do X, Y, Z, right? But then you can layer on top of that, here's what you need to have in your quality report and your outcomes data to then receive a bonus payment as well. So you're sharing those data with your Medicaid division, with your behavioral health division. You're looking at those cost report numbers. And so there provides some transparency in both what you're doing, because the state could very easily say and go back to say, this isn't something that, we're approving because of, A, B, or C reason. And so another kind of key difference is that the state owns the model very much so, as opposed to what we see with a number of different types of models where it's, federally qualified versus community certified or state run. And so there is that kind of difference in kind of reviewing those cost report and reviewing those data so that the state has a lot more ownership. So gave you a few different elements there, right? Both that the state has a ability to kind of fine tooth comb what clinics are billing for, and also for their quality outcomes to see, does that kind of reach the threshold for a bonus payment, or is there a need to kind of relook at that rebasing structure? But then also that element of really where and how are folks doing, from this financial structure. So there's a bit of nuance and a bit of difference there, but the state ownership is a key component.
Thank you. I am going to try to breeze through as many questions as I can. So if you see me speeding along, that's why there's a whole host of questions here. So thank you, everybody. And so the next question is, obviously, in your presentations, that's pretty positive towards both of these models. What challenges did you face when establishing FQHCs and CCBHCs?
I could start with that one. I mean, as far as the integration piece, is that what you're speaking to?
I think just adopting the model. Okay. If someone were to bring it on.
Yeah. Well, here in the Northeast Kingdom, we started just, where there were small clinics, people coming together in the community and seeing a need for medical care, and establishing the clinics. And then over time, it was built into an FQHC system. As far as the integration piece, it really is, bringing those two worlds together, in the cultural shift, and, what is the benefit to myself and my patient, like from a provider viewpoint in doing this. And I think, we've proven over time, that it does provide comprehensive services to our population.
Any other challenges people want to speak to?
Yeah, I think some of the challenges that we faced in rolling out the CCBHC is, because we were the first in the state, is really a lot of just the basic education of what CCBHC is, both to our staff and to our community as well. And it took a long time, I think, for our staff to really understand the model before they could fully embrace it. That's where we had spent a lot of time in just that, communication. What is the philosophy? What are we trying to do here? How does this benefit the clients that you're serving, before staff got on board with it and they could understand it and how this benefited the clients, because it was just so new. And they're so used to sort of that siloed way of thinking and that fee-for-service way of thinking, that the thought of really sort of removing some of those barriers that they've always run up against in trying to provide care, it's just so ingrained sometimes in how mental health providers sometimes are so used to thinking, that the concept of actually just being able to provide care, it was an unexpected barrier that we ran into, that the CCBHC model was freed us from. So it was kind of a barrier, but also a blessing in some ways.
Thank you. Next question. What is the longevity of these models? Grants are great, but long-term finances and sustainability, how can you achieve that?
So this is the essence of my job, just to kind of give some insights here. So grants are a stepping stone, right? And so we have 400 plus clinics that have received grants in the country. And what we seek to do is to work with state partners to then establish, either through an 1115 waiver or through a state plan amendment, to have CCBHC as a provider type within their plan. And so what that is then saying for those clinics that reach a threshold or can achieve the criteria that the state defines for integrated care, for care delivery, for quality reporting, for a number of things, they then are able to receive that PPS rate and potentially that quality bonus payment. And so it is up to the state to convert the model from one where the feds are providing grants to clinics to the state owning that process and owning that structure and providing that. So it is that handoff. So think of it like you would think of other pilot projects where you get federal dollars to establish something. You look at the data and the outcomes. You see, wow, this is making a huge difference. People are happy with it. Folks are getting healthier. Outcomes are strong, and then the state can then own that and convert it. What we see as being a real huge benefit that is happening right now is that CMS has stated, because crisis response is a required element of the model. So CMS has stated that there's an 85% enhanced match for mobile crisis response. So that means for every $100 spent on something, the federal government's paying 85 of those dollars. That they recommend that in establishing that, that you do it through the CCBHC model because of that requirement. So you're taking from that mobile crisis response, so urgent acute care need, to long-term care maintenance for someone who has a mental health or substance use need. And then CMS kind of layered on top of that, so this requirement that states have for 988 to establish the behavioral health equivalent for 911, that the technology piece can also be part of that. So now if someone's calling and they have suicidal ideation, they're looking to receive supports for their behavioral health condition, even that phone call can then be linked all the way through to someone's care needs. So it does establish this foundation from initial need to long-term care maintenance that I think is important. And so we are seeing states kind of taking that grant opportunity and building off of that to convert it into something sustainable for the entire continuum of care.
Thank you. Another question was related to children and adolescents. Do you all have any examples of how your work with children and teens has been received by families in the community? Any success stories or lessons learned to share?
I can speak to that. Certainly, we see children, teens in the offices, and it's a matter of helping them to resolve whatever difficulties they're facing in a short-term model, and then connecting them with community resources as far as a community therapist if they're going to need long-term treatment. But certainly, we have positive feedback from patients and their families in that population also.
Yeah,
I can give. Oh, sorry. Go ahead, Christy.
I was just going to say, I think part of some of the services that we offer are school-based clinicians and things like that, and CCBHC just continues to sort of enhance, the work that we do in our schools and with our BIs and different things like that. So, our DA structure and, the CCBHC work that we do, just continues to enhance that work.
There's one really good data example I want to use, and it's from New York. So in New York, again, they having the CCBHC model statewide, they're tracking their data. They saw a 24% increase in children's behavioral health services within the first year of the model. And they attribute that to being embedded into schools, so middle school, high school, and elementary schools. But one of the things that was anecdotal from clinics that they heard was that when those kids got introduced into care, it then brought those parents and grandparents into care. So breaking, intergenerational cycles of untreated mental health and substance use care need. So we talk about, kind of this no wrong door, but the model really does help to create those doors where they didn't exist previously by embedding staff or by embedding technology or by, paying to train staff in those facilities, in those clinics. So you are, increasing that access. Also, when it comes to substance use, right, we know from research that a family-based approach is really important. And so we're seeing clinics from their needs assessment and then saying, well, we need to build into our cost the ability to do more family-centered, family-focused care because we are seeing kids with substance use conditions developing or, at risk of this. And so how do we kind of do that by both, from this brick and mortar perspective, but also from the need and focus of our staff in training and in the provider types. So we do see, a lot of opportunity there to innovate. And it just is important to note that, of the criteria of the model, like there are 6 criteria from the staff, access, care coordination, quality reporting, et cetera. There are child welfare elements within every single one of them, including the quality reporting. So not just, what's our follow-up with children and youth, 30, 60, 90 days out, but also looking at, what's their BMI, also looking at data around, what partnerships are you having with different child welfare systems and what is that yielding? And so there's a number of different criteria that clinics have to report on when the model is established for that PPS structure. And I think that's just an important element when we think about access to care for anyone of any age.
One of my group's questions was, we're still talking about 2 systems. And when we talk about FQHCs or the CCBHC model and one having a more heavily core focus on medical, what do you think the barriers are to getting to one system and one model of whole health?
I think part of it is that, we're talking about 2 systems that complement each other, and certainly from, the top down, we could look at, how to shift that. But for primary care, we're generalists in all ways. If somebody comes in and they have a cardiac issue, we're going to refer them to specialty care for a cardiologist. And I see that as being the differences between these 2 systems. The CCBHC is the specialty care that is necessary. And so I see us more as a collaboration. And, if that could get to a point of being one system down the road, all the better. But I think both are important, and you can't have one without the other.
So this will, sort of reveal my bias about payment and delivery system reform. There are a million different problems that you could try to solve. And I think one of the things Vermont's healthcare reform efforts is supposed to get at, right? And I'll leave that deliberately ambiguous, that's supposed to get at, is that the incentive matters and the incentives are frequently wrong, right? There is not a lot of incentive for these organizations to be more closely aligned on a business level, right? And we have lots of good people doing great things and trying to do integrated care for people who need it when and where they need it. But if you wanted an integrated system of care, you would have to change some of the financial incentives, right? You would have, that's why I'm so keenly interested in getting FQHCs over to a capitated payment model, even though it scares the heck out of lots of FQHCs, because I want to be able to make investments in things that are more likely to integrate care. And the current encounter rate methodology makes that really hard. I can have all the good intentions I want, but I get paid when beneficiaries go through my door and get services, period. And so my desire to create an integrated system of care runs right up against my fiduciary obligation to the corporation. And so I think you've got to, if you want to change care, you got to change finances. And if you want to change your finances and what you invest in, you got to change your payments. And so I think to get closer together, we need to be able to buy different stuff. And I can only buy different stuff if I get paid in a different way. Sorry if that answer was elliptical, but I think that's one of the primary barriers to closer integration.
No,
Michael, I
really,
think your answer was perfect. Sorry, Allison. I got so excited from your response because that's really part of the vision of CCBHC, and in places that is integrated much, better or more seamlessly in others, right? So for us, because CCBHCs, and I say us, I'm here trying to orchestrate this at a much more national level. At the clinic level, if there's a need within for a homeless population, CCBHCs can go out and deliver that, and they receive that encounter rate in the community. Now, if you're, liaising data from an FQHC or sharing patients, that's another revenue stream for you as well. Similarly, if we're going out into the community and we're screening and we're seeing, wow, there are folks here who may be at risk for things like, endocarditis and a number that need to be connected to that. We can then, in a coordinated effort, create this kind of primary care where you're receiving more encounter rates because of our kind of coordination there as well. And then we'll be able to share that. So this is this symbiotic incentive payment structure because of the more flexibility of being a community-based model and not a clinic-based model. So being out in the community and being embedded where there are, it does just kind of create this recipe to alleviate some of those things that you were just talking about. And I think, it'd be great to kind of put pen to paper and map out what that could look like.
Yeah, I appreciate your comments on that. And for me, I kind of think of it as this Bermuda Triangle where like the fee-for-service methodology is part of it. But then a lot of people have written about the so-called wrong pocket problem and long pocket problem, in that, hey, I can save lots of money by avoiding emergency department utilization, but those savings are going to accrue to the hospital, right? In Vermont's Medicaid program, which is like the home team, like I love them so much, they set up a clinical pharmacist program, which I think is a huge step in the right direction. But it's not properly funded because they have a interesting hypothesis of, hey, you should fund this through fee-for-service billing and some savings, but FQHCs are not a risk-bearing entity in the current healthcare reform efforts. So there's no way for us, we would spend the money up front, but there's no way for us to save the money because it goes to the wrong pocket. And then the long pocket problem being that stuff that would really, really matter is going to take like 10 or 15 years to pay off. And people are seemingly more interested in savings in healthcare reform than sustainability. And I'm a little pessimistic about that. I think it's about building a sustainable system. And so I think those are three big gnarly problems to solve. I think, which is why solving the payment methodology problem seems like the most straightforward one in the short term. And I think, CMMI seems to be getting that. And so I think there is some momentum to try to figure out how to change those incentives to promote further integration.
Yeah, I think this conversation is one that I'm hoping people are having in their work groups as well. It came up in our small breakout talking about how if we wanted to benefit the system and the DAs maybe took on an outcome to reduce ED utilization, that it comes at cost to them and the savings doesn't come back to them. Same for, UVM Health Network focusing on access to care. That's a system-wide benefit, but that's at great cost. And so it's about doing the right thing and how do you decide the value of value and where does the cost-saving conversation come in? So thank you for teasing it out that way. That was really helpful. I'm going to go to the next question. And this is one that I think would be specific to Brett, but possibly Christy. And it's about, could we hear more about the nuts and bolts of need assessment? How is that funded? What were the findings? And what is it?
Yeah, so I can talk about, we needed to do, as part of the grant, a community needs assessment within 60 days of our grant award. And what we did is actually send out a survey to all of our clients, all our community partners in the area, to our community in general, and really started to take a look at what are the barriers that people have to care, what are the strengths of our current mental health system, what are the gaps of our current mental health system, what services are needed, and what, like I said earlier, if hours are the issue of what are preventing people from coming in, what hours would people want our clinic to be open in as well? And then as we started to take a look at like, what are the barriers to care? Then we started to take a look at, okay, how do we start to address those? If transportation is a barrier, how do we start to work with the case managers that we have to either enhance our transportation services or work with our local partners like Tri-Valley Transit? Is there something that we can do there to help with our transportation services to get people into services in a more streamlined fashion. If childcare is a barrier, how do we look at helping to assist with childcare so people can get in for services? So really trying to look at the whole gamut of what are the needs, what are the gaps, what are our community partners seeing as gaps in care, and is that a service that we can develop under the grant here, or work with our community partners to develop that together in some way. And that will be something that we need to repeat that assessment every 3 years going forward to both see, are we making some progress on any of those gaps in services and those barriers? Or are there new things coming up that we haven't necessarily addressed or that have newly developed that we need to now focus on moving forward as well? So at a very basic level, that was really what our needs assessment started taking a look at.
Thank you, Christy. A follow-up to that, in terms of how it was administered, are you answering those questions yourselves? Did you send out a survey? Did you receive any technical assistance or have an independently assessed?
Our needs assessment, we sent out a survey. We were very, very basic. We did it on SurveyMonkey. We had it on Facebook. We had it on paper for the clients that did not have access to technology. As we had staff members going out, we left a paper copy and helped them fill it out if they needed assistance with that as well too. But tried to make it available in as many different ways as possible.
And so from a clinic perspective, that's exactly kind of what you do. You do this needs assessment with your community, looking at that. You can also then talk to your peer and partners to say, where do you need help, right? So if you're looking at your schools, if you're looking at your FQHCs, if you're looking at your law enforcement, what do you need right now from a mental health and substance use care provider space that we can then do? We see this happen. So I'm currently working with a state, and they identified that, and I kind of alluded to this previously, their court systems, right? So the courts are the stopgap prior to someone going to jail. And so their judges, public defenders, their DA, they need more resources for mental health and substance use. And so the CCBHCs are providing technology or providing embedded staff to conduct screening and assessment and diagnoses to then have a fuller understanding of, who's going then before the court or who's having, before their final disposition. And I think that's a really key point to think about too, is, what can the CCBHC do as a community space, as a community provider that is, maybe atypical? Where are there other needs in the community space that are there? And so, conducting those kind of initial needs assessments statewide from a state policymaker perspective, or at the clinical level, figuring out kind of where that is, because the goal of the CCBHC, I keep saying goal, and I should actually say a component of the CCBHC model, is to then have a clinic-specific rate that meets those clinic-specific or community-specific needs. So you can embed and create that to craft, the ability to hire and recruit staff, or build in the technologies needed to then be able to meet those needs, both in the immediate future but long term. So the needs assessment can. There are some key components we can share examples of needs assessments. If folks are interested. But the kind of thing that I think is important is that, what's going to be relevant for Vermont in a needs assessment, kind of based off its own histories, lived experiences, infrastructure systems, may be different than what we see, in a state like, Oklahoma or Texas.
Thank you. Our next question focuses on hearing the panel talk about how the goal right now is collaboration. And so if that's the case, how do we avoid duplication and parallel processes and parallel work? And that came up in some of our breakout conversations, from everything from the amount of providers, nurse practitioners, psychiatry, LCSWs, but also, if you are both screening, you've got a PHQ-9 happening at the FQHC and one happening at the DA. How many well-qualified data informatics folks do we have that analyze that information? And is it useful to have one person over there analyzing PHQ data and another in the same community? And have we thought about combining efforts?
the intention for the CCBHC, with the quality reporting, they have to report their data. Now, if there's another entity over here that's doing data and they can create a either financial or non-financial mechanism to share those data so that they can then share the full picture of what's needed without duplication, and creating that system, that's going to be an important kind of task and vision for them to be able to do that. Now, again, that creates a revenue stream for this other partner because it's built into that. And also, if the state does have a quality bonus payment, that quality bonus payment is dictated by the quality of the data, but also that data itself. So if there is a partner that could benefit from that quality bonus payment because they're also sharing these data and acquiring them, tracking them, et cetera, and then creating this kind of interoperability and kind of clinic support, that's going to just help all of these providers to get that support and those benefit and that additional revenue. So we don't ever want things to be duplicative, but we want accuracy and we want to make sure that there's a streamlined nature. And the model, should the state choose to have a quality bonus payment and in addition to that tracking, does create that added incentive to share those data. So even if people are doing similar things, it's all going to be the same, a true vision of really what's being of what's happening there.
Does anyone else want to speak to duplication, parallel efforts?
Yeah, I mean, I think Vermont has been working on that, through the years, through the blueprint, and not duplicating services and tracking quality metrics and, having the information in one place as much as possible. That's something that we've had work groups locally and throughout the state trying to accomplish.
I'm not sure. I think I'm hearing the question in two different ways, like how do you avoid it, duplication, and then how do you promote interoperability so people can have the information when and where they need it without, people coming into our office and feeling like they're visiting the CPA and they've got to fill out 10 different things. For me, on the duplication part, that has been really tricky. When we did the all-payer model agreement with CMS, we fought for a year about what the quality measures would be. And that conversation rotated around the pole of, hey, we are required to collect tons of stuff from our paymasters. What additional do you want us to collect? Right? Because the answer is always well, more. We just want more. And so I think there probably does need to be some sort of reckoning of hey, what are we just required, whether, Vermont has an opinion or not, what is it that we're required to report? And then what else do you need? And then I think that at least in my own leadership practice, it is important for us to stay action oriented because there's this thread that runs through Vermont. I'm criticizing all of us lovingly, where we sometimes forget that convenings are supposed to be a means, not an end. Hey, let's just get everybody in the room. Well, let's get everybody in the room to do what? Right? I used to joke when I was at AHS, we'd have a meeting, we realized some people weren't there, so we'd cancel the meeting and invite more people. Then we'd look around the table, realize we still don't know how to have everybody, invite more people. The third time, we'd finally have everybody around the table, and then we're well, the problem's too big, we can't do anything about it. So I think it's just there's a level of candor about, hey, are we duplicating services here? What's actually going on? Where are we trying to go? And I think we just need to probably make that a higher strategic priority of what are we duplicating here? Does it already exist? I think to go back to Northeast Kingdom Human Services, this is my own editorial comment. I think one of the challenges Kelsey and the team have up there is that people are well, the DA should do this or the DA should do that. And it's pretty clear that people in the community don't actually understand the services that the DA actually offers. And so I think some real effort needs to be put into what is actually already existing in our ecosystem before we build new stuff. Because people want to push us towards new, but a lot of it's out there. It just may not work the best way because of various operational concerns or workforce concerns. So a little off topic, but just what came to mind.
I think that's come up I'll speak for myself, but I've heard this from others a million times with just this group convening and the work groups we have. I mean, I sit in a group with Mary Kate Molman and Christian Pulcini from UVM Health Network, and I'm tossing out something that I think is just wildly creative, and they're like, oh yeah, that already exists. And so we don't know what's out there. And if there's one goal, I don't know if you've helped my anxiety or made it worse, Michael, but in thinking that, like, if the goal is convening, but not to necessarily have fixed the problem, we're certainly doing that well right now because we're only 3 meetings in my work group. But at the very least, I now have a map in my head of the system that's grown threefold just by
Well, that's perfectly fine. I mean, I will tell you that the other like kind of companion problem that I see is part of what makes us great is we are so small and we kind of know everybody. But small numbers are hard when it comes to creating models. I find sometimes our own team and some community partners tie themselves in knots to try to create something new that would really only benefit like 5 people. And that's really hard from a systems approach. And so, like it took 10 minutes of looking through the local hospital's electronic medical record to say, hey, I know you want to build this whole new program, but this is like 19 utilizations per year. Can you really build a program around 19 utilizations per year? Well, you could. It's going to be really, really expensive to do that. Is there any other way in this ecosystem, if we've fully fleshed out the ecosystem and understand it, that we can help people? And so I think, understanding the tools we have and then maximizing them is probably, worth a little more effort than re-envisioning every single thing, right? Because if we can get there, we can figure out, oh, here's the actual gap that we have.
Agreed. I think we have time for one more question, and then we'll be moving into work groups. And as Kathy mentioned, we are going to work to get you answers to the full list, and that'll come in a different format. So the last question for this group is, what are the outcomes data that you have? What has each model improved regarding health and well-being? What can you point to when you're trying to show off the success?
Well, one thing I'll share with the group afterwards is there are those quality metrics that are required by the state and required by clinics. Grantees report the NOMS data, which are different. There are some similarities in alignment, but just so that folks can see kind of for those states that are implementing the model, what data are coming out. We do see that for CCBHCs, there's a lot of different data, and I'll just kind of briefly share some of those outcomes. So that way, we can kind of see what some other states are looking at and seeing. In Missouri, there was a 20% decrease in hospitalizations in 3 years, and for specifically ED visits, it was 36% decrease. They saw statewide in 3 years a 23% increase in access to mental health and substance use care. And from a primary care perspective, those who were in care at a CCBHC saw a 20% decrease in cholesterol and about 1.48 decrease in hemoglobin A1C, which is, of course, tied to diabetes. In Texas, they were able to decrease their wait lists to 0 at all of their CCBHCs. And at their CCBHCs, there were 40% of the clients were those who had more complex SMI and SUD compared to 25% of non-CCBHC, either mental health or substance use providers. And then in New York, from an overall cost perspective, they saw a 20% decrease in monthly costs for inpatient behavioral health. And then for inpatient services overall, they saw a 20% decrease in monthly costs. So again, and kind of thinking about, Michael's example of, the wrong pocket or the long pocket, it does really rely on the state to kind of have a sense of really where are we seeing those and how can we shift to look at some of those, to look at those dollars to elevate what's working well while still supporting and not, penalizing those those facilities for where those partnerships can be shifted, when those costs can be shifted. We have data from a number of other states. Clinic data are really outstanding, but I wanted to share those statewide data since this is a statewide conversation.
I would just say, we're only two quarters now in since the grant went live. So we are just in the spot of starting to track our outcomes now, but starting to track all the different types of services that the grant has allowed us to provide that would have gone uncovered or unprovided, whether those were voc services, medical services, the number of screenings that we've been able to do, the number of additional therapy services that we're able to provide, and the number of uninsured folks that we're able to serve, or underinsured folks that we're able to serve as well. So we're just starting to sort of build our outcomes portfolio based on what the grant has been able to do for us as well. So that will be more forthcoming.
Great. Any other last notes? Okay. I'll just point as I saw Alexa and Andy put some nice comments in the chat. So get a chance to review those, and I'm going to turn it over to Kathy for next steps.
Great, if I can get unmuted. Thank you again. I think that was really great. We do have more questions. If your question hasn't been answered, we will follow up and get answers. So panelists, expect emails from me. And then you've all should have an invite on your calendar for a work group. Those of you who aren't officially on a work group, we've already put people into work groups again, dealing with teams, making it easy. So please go join those work groups. We're going to come back out at the end to hear the report outs from the work groups and have our public comment period. So thank you very much, and we'll see you in the work group meetings.
Alexis, would you be open to going to the pediatrics subgroup to observe? All right, I'm going to send you that link to your email. You are muted right now, so I can't hear you.
To speak there, they let me speak at the last meeting, I know.
Is pediatrics a good one, or would you prefer one of
Yes,
the other?
no, it is. I have some good ideas that I came up with about that. Just not that long, but just a few really, because I've been studying trauma, and they have the trauma conference that's like worldwide is still going on for free. I wanted to let people know about that. But I took a lot of notes when I went through it. And so I was just going to share a little bit of what I see as something to help, like with the pediatrics thing. It won't take long, no, I promise. I'm started to talk less.
It's all right.
It's a good
Chat.
thing.
All right, so I just sent you that link to your email, and it should work. And I'm going to go pop out of here and check in on groups.
Okay, thank you.
You're welcome.
All right, let me see.